over 25 PRP injections per month for several years without running, ads, without any marketing budget. How did you build that volume?
No better marketing tool than a satisfied customer. They say, you know what, Dr. Ortega did my PRP. You know what, I am back to golfing again. You should go and see him. You're going to get a patient who's going to be satisfied. He's going to tell his friends, and the friends are going to come back to you.
What's your rebuttal, or how do you talk to them when they say, oh, I've seen that PRP is $1,000. It's not worth it?
I almost see it like making an investment in your knee. I see patients that have spent in cosmetic surgery thousands of dollars to get, one wrinkle out of their eyelid, and they don't want to invest themselves on things that are keeping them from walking or from having a good time dancing. How good is it for you to look good and not able to dance because your knee is hurting?
Where do you think the biggest gaps are right now in how doctors explain PRP to patients?
Patients are not being educated the way they should. You just cannot tell them that this is PRP, we're gonna inject it to you, you're gonna feel fine. They need to understand what they're getting. They need to feel comfortable. It's costly, you're not talking about a $20 procedure here, so the gap to me.
Dr. Ortega is an orthopedic sports medicine surgeon with over 20 plus years in practice. He's located in Palm Beach, Florida, and he's been doing over 25 PRP injections per month for several years. And, I reached out to him because I think it's a very important topic to go over, because I feel like a lot of doctors, they focus on the clinical aspect of PRP, trying to get the science, the formulation and all that. But I don't see many people talk about how to talk to the patients about it, how to educate about it, and then, certain frames on how he talks to the patient. So I reached out to him and I said, Dr. Ortega, you've been doing this for a while, consistently, without running, ads, without any marketing budget. And so I reached out and I said, I'm like, Dr. Ortega, I think you have so much knowledge here, and I would love for you to share it to our audience and provide some value. So Dr. Ortega, thank you so much for joining us. How are you today?
I'm doing well. I apologize for the background. I'm in a hospital. My mother had colon surgery 2 days ago, so I'm in Puerto Rico in a very remote place. This is where she lives. So I'm sitting on a chair, which is not very comfortable. I'm freezing myself because it's like 68 degrees in the room. But my mother is right next to me, and I'm happy for her that everything so far is going well for her.
Yes. Likewise, and our prayers, and I'm glad that
Thank
you
you.
are here with us as well. You're very welcome. And so I would like to start with, when did you start seeing that PRP should be a big part in your practice, right? Because you're an orthopedic surgeon, right? And I know you do surgery. And when was that moment that you're like, I want to focus on PRP a little bit more? And when was that switch?
So, just to give you a little background here, when I did my training at the Cleveland Clinic in Ohio, there were some patients that were having some pain, residual pain in after an ACL reconstruction where you have to harvest tendons, and nothing was working for them. They were on anti-inflammatories. Some of them had even had steroid shots. And we started working, doing some PRPs back then, thinking that, the body has its own capacity for, to help with the healing process. And some medications at some point don't work anymore. So we were doing PRP injections for inflammation, for tendinitis. Then I moved to Florida, and we started our practice, and hyaluronic acid was very popular. And we were still doing cortisone shots as well. But there comes a time when, the patients want more and they deserve more. And so roughly like 10, 12 years ago, I started to read more and get more familiar with the process of using your own body's ability to enhance healing. And I started working with PRP and dedicating more time in explaining the patients options as far as treatment for arthritis and tendinitis. So I'd say about 12 years ago, it's more or less 12, 15 years ago is when I started doing it heavily.
Okay. Yeah, thank you for sharing that story. And I know that we've spoken off camera here, and you've said that you like and you love doing the PRP yourself, from drawing the blood to, obviously, maybe you have your team spin it, but then you like to inject it and use the ultrasound. Why do you do that rather than delegating that to, let's say, a PA or a nurse practitioner to work to do those things for you?
I believe that when the doctor is doing hands-on on a patient, the patients are more comfortable knowing that it is a doctor doing the procedure. And I try to, as we're doing the procedure itself, like taking the blood, which is sometimes a little difficult depending on the patient, but they feel, I think that they have a little bit more of they feel less, the stress is a little bit less. I'm not saying that a nurse practitioner cannot do it or a PA, but I believe that if a doctor is doing it itself, the patients feel a little bit safer for some reason, and they trust the procedure a little bit more. Um, the ultrasound is a tool that I use because I like to show the patients where the needle is going. Like if I'm injecting, for example, let's say for giving you a lateral epicondylitis, or I'm injecting an Achilles tendinitis, or I'm injecting a plantar fasciitis, or even a biceps tendon. I like to show them, and it's just a form of relaxing the patient, knowing exactly what we're doing, and that they can see it with their own eyes, not just we're just going to put the needle here and hopefully we're going to hit the target. I think that it's just a peace of mind for the patient.
Yeah, I agree. I agree with that. And so when you're seeing patients all day, what is the ideal for you, in your experience, the ideal PRP candidate? Like, you see them and you're like, okay, this would be perfect for a PRP treatment.
For arthritis or for anything.
I would
You
say
want to
in
start this?
general, right? So, like,
Let's start with arthritis first, okay? Arthritis, like for example, let's take knee arthritis. Um, the ideal candidate for me is a patient that has maybe a grade 1, 3 at most arthritis on a Kellgren-Lawrence scale. You don't want to do it on somebody who's got varus alignment and bone on bone, because you know they're not going to get a whole lot of benefit, and it's a costly procedure. So the ideal candidate for me is someone who's got the beginning of arthritis, moderate arthritis, who is or had at least tried anti-inflammatories and cortisone injections, and some of them even already had tried hyaluronic acid injections, and they don't get the relief they expect or anticipate. So that's an option. The PRP has been proven that has worked better than hyaluronic acid and has worked better than steroids, especially in the long term. So
yes,
you want to do a patient that is not on terminal arthritis, grade 1 to 3, who has not done well with other treatment options. For tendinitis, I use it for anybody who's had a good 6 to 8 weeks of conservative approach with anti-inflammatories. The pain persists. Cortisone shots have not done anything for them. And I don't like to inject patellar tendons or Achilles tendon with cortisone. I go directly for the PRP for those. For tennis elbow, maybe a shot of cortisone. If it doesn't work, then they get the option of trying the PRP, which is about 70% effective.
interesting. Okay, so you mentioned a little bit about so you said arthritis. Cool. You went over also all, what other candidates are good. So, Um, is there any other candidates that you see and you're like, this patient here is not, PRP is not for them? What other candidates that PRP you think will not work well on?
All right, so there are contraindications for the use of PRP. That I have. Over time I've read about patients that have like low platelet counts, that some patients have ongoing infections. You want to make sure that you don't want to take a patient with an infection somewhere in the body, draw the blood and inject the joint, because then if there is some kind of a septicemia or something like that, then you're going to transfer that into the joint. Patients that are taking like Xarelto, Plavix, Eliquis, it's not recommended as well for some reason that the platelet function is not as good. Those are the big ones. But most patients, they're healthy and they don't have those problems. So it's a very low percentage in my practice.
Yeah, I know that when we were building your website and I was getting to know more about your practice and all that, what would you say your success rate would be in when you inject PRP?
High. I
Yeah,
would say over 75, 80% success rate. Better than anything that I'm using
nice.
right now. Better. I don't do
Yeah,
I don't do bone marrow, not yet. I think it's a very expensive procedure. And I don't think the results are that different for function and for pain relief. Um, so for example, like lateral epicondylitis, I patients one PRP injection that came back for a follow-up appointment. Excellent results. I have patients 6 months, 8 months with PRP. They doing it maybe twice a year. Results better than hyaluronic acid, and results are better than cortisone. Cortisone is a good thing for a short term. And if I see a patient that, for example, comes to the office with a swollen knee where there's a large effusion, I probably drain the effusion first. I give him a cortisone shot. I allow the knee to cool down, dry. So when they come back, like in 4 weeks, then I proceed with the PRP.
got it. Yeah. Okay. Um, Thank you for answering that. So I think one of the main reasons why you have a high success rate, right, is because I think your patient selection is pretty spot on. So, for those, let's say that that PRP will not be a good, they're not a good candidate. Um, Now let's switch it up a little bit. So the let's say you chose a good candidate, you treated, you used PRP, and let's say PRP didn't work. What do you think went wrong there?
Usually, when that happens, is at least in my experience, is that you're trying to help somebody who is either at a very advanced stage of arthritis that is not patient is not still thinking about having like a knee replacement. You're doing it on somebody older with other problems like stability of the knee, that have a very bad alignment of the joint. Um, and quite frankly, you can't really assess, the amount of platelets you're injecting at one point. It varies on patients. So it's hard to tell whether these patients have healthy platelets too. So it is a variety of conditions, but in my hands, I think the worst candidate or the ones that don't do well are the ones that have advanced arthritis or some other problem with the joint, like either instability or malalignment uh, of the joint itself.
Okay. In our conversation, you mentioned that you framed PRP as a restorative um, treatment or an option, right? Why do you use restorative, and why does it matter?
So the studies that are coming out, and there's a lot of information coming out, shows that PRP has been known to stimulate cartilage repair and slow cartilage breakdown. There's a lot of growth factors in the platelets that help to decrease inflammation by fighting the cytokines that cause inflammation. And The word regenerative, I like to try not to use that word too much. I like to use the words more as um, delay progression, improve function, decrease pain in a natural way without side effects, without the effects of a cortisone shot in some patients, which are sometimes could be really bad, high blood sugar, to give you an example. So I think that the slowing the degradation process of the cartilage, when you tell a patient you're doing this because you want to try to delay the progression of arthritis and maybe even, I'm not going to say it's going to postpone or delay a surgery for permanently, but at least you have a chance of doing this by helping the cartilage to uh, repair itself to some degree.
Okay. Um, in your practice, let's say, usually when patients come in for an appointment, let's say they're expecting for you to a cortisone injection or an HA injection, right? So for those patients, when you see that, like, how does that conversation go? Because I think that's very important, right? Because like what you were talking about earlier is that I feel like a lot of doctors just default to cortisone, all right, or hyaluronic acid, and they have their place. But how, for those patients that are expecting that, how does that conversation go with them?
So I asked him, first of all, when they come to the office, some of them already had treatment and some already had been in anti-inflammatories. Some of them even had steroid injections, and there's some PCPs that do their own injections. So I take a full history from the patient and I go, like, for example, so what have you done for your knee pain? First of all, how long you had the knee pain? And what kind of treatment you've had so far? Well, I've done this. I have done the therapy, doctor. My primary had me on the ibuprofen 800 twice a day. I didn't get any relief. Then I went to see this other doctor who gave me for just to give you gave me hyaluronic. It didn't work. Uh, and as I've been marketing myself around the community with some primary doctors, they know that I do my PRP, so I give them the option. It's just an option of trying a different way of treating arthritis, which happens to be superior. Um, Keep in mind that this is not covered by insurance, not yet, at least that I know of, and the hyaluronic acid is some patients want to try the hyaluronic acid first because it's covered by insurance, and sometimes they've already done that and they're not satisfied. So once I eliminate all those variables, I take the time to explain, the PRP as another option, and which in the majority of the cases works better.
Yeah, yeah. Well, we know that hyaluronic acid and cortisone, they don't have, healing properties, right? PRP does, right? What are the biggest, biggest misconceptions that you see that when patients come into your practice? Like, what are those, or because I'm sure they're skeptical, right? So, what are some misconceptions and you have to like educate them?
So I don't exactly. There's some advertisements that are wrong, and I don't never tell a patient that a PRP is going to bring a knee from a 65-year-old to a 25-year-old stage. That is not going to happen. It's not one PRP injection and your knee is back to is 35 years younger. Some people market them as stem cells. They're not stem cells either. Um,
It's a very good point. I do see that often a lot.
they
Yes.
use that term, and that is a dangerous term to use. PRP, they're not stem cells coming from the bone marrow. This is a much more expensive procedure. Um, I will never tell them that this is a permanent thing. It's not like one shot is permanent. They have to come 2 3 times a year, get the injection, and get the relief, the function the places don't work immediately. It takes about 6 to 8 weeks for the patients to start experiencing the effects of the shot itself. So it's not like one shot is an immediate pain relief. That's another misconception. It takes time for the PRP to peak, which is roughly 6 weeks out. So I think those are the biggest one. Um, they're not going to restore the cartilage completely. They're just a part of repairing. It's to slow the progression of cartilage breakdown. I see it more stimulating repair to some degree, reducing inflammation and improving function. Those are the main things that I tell my patients.
Keep it simple, and I feel like by keeping it like that, they understand, and that's what they want to hear, right? Because they want to make sure that they feel better. For those patients that are expecting, that have had, let's say that they're in pain and they know that with a cortisone injection they feel relief, right? Almost immediately, right? And what those patients that are looking for that type of relief with PRP, how do you educate that, or how do you explain that to them?
So I told them the difference between cortisone and PRP. Cortisone will give you an immediate effect. I mean, some patients, you get a cortisone shot in 24 hours, the pain it just goes away. But it's about a 6 to 8 week. Uh, uh, Most patients, 6 to 8 weeks of relief, and then the pain starts escalating again. And then they have to get a second cortisone, and then a third one, and then a fourth one. The more cortisone you put in your body, the more side effects you're going to get, including osteopenia, uh, fluid retention, weight gain. If you have blood sugar issues, you're going to get totally off, the charts. It's just going to be PRP. I told them that it's more like a biological process of your own body working to heal. When you have a cut in your cyst, like you have a laceration in your skin, that doesn't heal overnight. It takes time for the wound to come together and seal and completely heal. So I more or less the same thing with a PRP. Give it a time for a cut to close. Give it time for a PRP to work to shut down the inflammation process.
Perfect analogy. Perfect analogy right there. That was spot on. Uh, When a patient comes to you and, they ask, is PRP worth it, right? Is it worth, I mean, I've seen price ranges depending on, I mean, prices can vary, in the United States from $500 to, I've seen $4,000. And so like, what's your rebuttal, or how do you talk to them when they say, oh, I've seen that PRP is $1,000, it's not worth it? What do you say to those patients?
Well, I don't want to. If I wanted to say what I wanted, I probably would have been already in the street doing something else. But I just try to let them know that it's. I almost see it like making an investment in your knee or your body. You're using your own God created um, uh, system,
Healing workers.
healing system to slow down. And in some cases, I'm not saying it will, but in some cases, slow down and maybe even prolong for years the possibility of a joint replacement. I see patients that have spent in cosmetic surgery thousands of dollars to get one uh, wrinkle out of their eyelid, and and they don't want to invest themselves on things that are keeping them from walking or from having a good time dancing. So, how good is it for you to look good and not able to dance because your knee is hurting? So,
Yeah.
I just
Yeah.
don't, I try to be actually, I don't say in a form to make the patient feel bad. I just try to make it in a way that it's with a little bit of humor so that they can understand that I'm just trying to make them feel like they're going to be doing much better using things that are coming from your own body, which are not causing side effects. And I don't believe that what I charge, by the way, is not what other people are charging. I'm more like on the average within the 700 range, but it's crazy. Some people are doing $1,500, $2,000. I don't know what systems they're using, if they're more expensive or not. I think your product, the pricing is very good, and I think it's very effective.
Yeah, thank you for that. For those patients that, again, skeptical, right? Because I feel like a lot of questions that doctors get is skepticism, right? That what they read online or it hasn't worked for them. So, like, let's say, for example, someone that already tried a PRP injection with another doctor. I already tried it, Dr. Ortega. Will it work for me? Like, what would you answer to that?
So I always question who's first of all, what kind of system are they using? I have seen. I'm not going to mention where, but I've seen PRPs that actually are just a test tube. They're just putting a test tube to spin, and I'm not sure if they're using leukocyte poor. I don't know if they're using leukocyte rich. I don't know the process of harvesting. Um, uh, and I question myself, what case does it really make a difference? And I believe it does. Uh, the type of product that you're using now and how you're using it. How many cc's are you injecting into the joint? Are you just doing 1 cc? Was the harvesting really bad and you didn't get enough? Are they mixing it with something else? So those are the things that are not. I wish I knew, but it's hard to tell.
Okay. When a patient asks you, why isn't it covered by insurance? What do you say to that?
I tell them that insurance are getting away, saying that this is still experimental. That there's been some studies showing that there is no significant difference when you use it compared to other things like, for example, cortisone, but it's only on the short term. The long term PRP is superior. Um, I think the insurance companies are using that as a ways of getting getting away with not having to pay for PRP. They just call it experimental. Meta-analysis studies where they compared multiple studies. In one of them, it was about 2,000 studies showing the benefit of PRP over hyaluronic acid, improving function and in pain, especially in the long term, like 6, 12 months after the injection. I actually carry one with my hands, showing the patients, and I can show them this is a study that was done, and you can see where PRP stands in comparison with hyaluronic acid. I have it as part of a handout that I give my patients.
Okay. So a couple of things there that I'm writing down. So I've heard from a good amount of doctors that they say that they don't want insurance to cover PRP. And the reason why, like, I mean, it sounds like a great idea, right, for them to cover PRP. So then that way patients can have it more. But in a way, then they will dictate what to pay for a PRP therapy. So they're kind of seeing it from that side. What would you say to those doctors that don't want insurance to kind of get their hands in PRP because then they're going to dictate what to pay out?
Exactly. Well, that is a concern. Right now, PRP, the pricing is very good. I think it's a very good revenue for the doctor for once. I'm not sure if the insurance companies are going to pay, how they're going to determine how much they're going to pay, because the kits, the price varies. There's some kits out there that are $400. How are you going to tell a patient, I'm going to pay you 300 when my kit is 400? So
Yeah,
that is going to be tough.
yeah,
There's not one way. There's not just one um, brand out there there are multiple brands and they vary in price. So that's going to be tough for insurance companies to make
It's
a
true.
definitive pricing for PRP.
Yeah. You mentioned you give them a handout. I think that's very important because I don't think many providers are doing that. So can you elaborate or explain a little bit like what the handout says and even like of the timing of when you give them the handout, the patients, right? Like so how does that look like?
Oh, the handout is just a one page that I give the patient. What is PRP? What does it do? How does it how do we get it from you?
Obtain PRP.
How do
Yeah.
we obtain it? Um, what to expect? Um, who's the best candidate? That kind of thing. And it's a very um, easy to read handout that patients get as part of the office visit. You can be my first office visit with a patient. I tell them, you're getting your cortisone today. Here's a handout about this procedure that we do here in the office. If you're not satisfied with the PRP, I mean, with the cortisone shot or even hyaluronic acid, here's this handout. And if you can go to just like the website that I have, they can actually go in there and they can read more about, in depth, more about the PRP. But it's a very simple handout. It's a question and an answer, a question and an answer, which I can read in Spanish and English. So I do it on both.
Yeah. I think that's very important, patient education in that. And I don't think a lot of providers are doing that. And at the end of the day, I'll add something to there. So like, I'm sure patients, when they leave the office, they're going to go out there, ask for opinions. They're going to read on their own, go to Google, go to ChatGPT, and then they're going to start reading. So why not you educate them and you continue building that trust with them, right?
It
So I
takes a
think
little
that,
time to do that. But this is not a 30-second discussion with a patient. We're talking about a good 5 minutes in the office explaining, trying to make the patient feel comfortable and trying to create a trust. Some patients don't trust doctors. Some patients are like, isn't this a scam? Is this, you have to provide them some science and some
yeah,
literature that supports what you're doing. And that little handout, there's a couple of references made as to things that have shown how this is superior to other forms of treatment that are non-surgical.
love that. That's actually really good. I hope for everyone that's listening, implement that. That will really drive an impact and increase an impact on PRP. So I wanted to touch something. So you're essentially, in a way, I like to say, like planting the seed, right? So, for example, if I'm a patient, I come to you and I'm due for a cortisone injection, even though maybe I get the cortisone, but then you're still educating them and like, listen, this is what cortisone is. It doesn't have any healing process. You educate them, but for next time, consider this. And so you're
Yeah.
planting the seed, I call it.
Yeah, 80% of my
Yeah,
patients don't get PRP as a first line of treatment. Uh, um, I try, like I said, things that are covered by insurance first, but at the same time, that same visit, they also get the 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 they get it educated. We're gonna try this first. This is what's going on. This is what we're gonna try, and then you have the option of doing this, and you should start reading about this. You should start looking ahead. What's going to happen if you're not satisfied with this first line of treatment that in some cases work, in some cases doesn't.
yeah, yeah. For the patients that you've educated them, you explained the difference between cortisone, PRP, and hyaluronic acid and all that, and they said no. Why do you think they said no?
I think that some of them are, honestly, in my opinion, they don't have the financials to pay for it. They don't want to sound like they cannot afford it. Um, and sometimes I try to make, payments, instead of coming with them all the money, at once. Sometimes they can pay it in different visits so that I don't get stuck with a big bill. Because my practice is there's a lot of um, uh, patients that have they're not in, most of them are Spanish, the ones that I'm seeing because I'm a Latin doctor, and some of them don't have the financials to cover that, and
Funds.
I believe that that's a is a big factor for them.
Yeah. Yeah. Yeah, it is. I mean, and I think, the your pricing is pretty good. It's not outrageous like, what we see out there. How important do you use, how important is ultrasound to you when injecting?
It is important when I'm doing. I mean, I can do a knee injection without ultrasound. Like if it's going intra-articular, I can do that very easily. I do the ultrasound because I like the patient to see what is happening. I'm like the process of them feeling more comfortable knowing where I'm putting the needle, making sure that if they're paying $700, that needle is going to go where it has to go, especially tendons,
Mm,
especially
yeah.
areas like are difficult to access just by feel, like a plantar fasciitis, a Achilles tendonitis, a even for rotator cuff tears that are partial, that are not responding to therapy, to anti-inflammatories, even cortisone shots. They'd like to see what they're getting, and I think that
Interesting.
they feel more um, uh, they feel better about the fact knowing that they're getting their money's worth by then seeing the procedure being done at the time where in real time.
Yeah. Yeah. And I think it also helps with like building that patient doctor relationship as well, right? Because you're talking to them like, you see this needle right here, you're showing them. So it increases trust. I believe you're increasing your relationship. So
Correct.
I agree with that. Yeah.
And it's
So go ahead, Dr. Ortega.
no, I'm sorry, I cut you off right there.
No, no, no. I was just gonna transition to another question, but go ahead, finish.
I think that that's a very important part. It's just I don't know if it's feasible for every doctor. To some doctors, they really don't feel like they should be drawing blood or they should be. But I like to do it myself, and I think the patients like it better.
Yeah. I mean, you're giving them the entire experience, you know?
Correct.
Yeah. Okay. So you've been doing 25 and more, 30 injections, PRP injections per month. Like I said, without running ads, without really spending marketing money. How did you build that volume? And like, how have you been able to sustain it?
The volume is built because once you start that pipeline, which is patients that have gotten PRP and they're happy with it, they keep coming to you because they want to repeat it once, twice a year minimum. And I've been doing this for a long time now. Those are the same patients that they were in the conversation with some friends, and they say, you know what, Dr. Ortega did my PRP. You know, when I am back to golfing again, feeling so well. You know, you should go and see him. So no better marketing tool than a satisfied customer, and that's what you're going to get with the PRP injection. You're going to get a patient who's going to be satisfied, he's going to tell his friends, and the friends are going to come back to you.
Yeah. So through referrals, right? And then obviously planting the seed for everyone that comes through, and continue educating them and, explaining the difference. Do you do you have any like referral partners? Like, let's say, like I think earlier in the conversation, you mentioned a primary care. What about like any physical therapy clinics that you have referral relationships? Like what other than your own ecosystem you have outside that can refer patients to you?
My partners, they refer me because they know I take the time and I do my ultrasound injections. I get referrals from um, uh, physical therapists as well. That they actually, some of them are even patients of mine. Um, But I believe that my biggest source of referrals come from my own practice, from my own patients, my own education on them. I think that's about 80% of them.
Wow. So how approximately how long did it take you to build up to do 25 plus per month?
25 per month, I would say probably in the last 4 years.
Okay.
Uh,
Wow.
I've,
It took you 4 years to build that up.
I would say about that. Yeah. And I'm right now, I'm now, don't be surprised if I ask you next week for another 25 because last month, I, I did like 32.
Nice. Yeah.
And
Nice.
when I took the course, I took a course on, biologics and the American Academy of Orthopedic Surgeons. There was a lecture. I was sitting was sitting next to another doctor who was doing 40 already, and so I don't know what's the
I want to
limit.
get to that. Yeah. Yeah. Um, a lot of doctors, a lot of clinicians, they struggle with this side of the business, right? To get it started. What advice do you have for them that someone that's starting off maybe doing once to 1 to 3 a month and they want to do more? Like, what would be your advice to them?
I would say to spend time with the patient, teach them, educate the patient, make them feel comfortable, give them some form of a handout. Um, Basically, it's going to be a patient to doctor to patient conversation that has to do a lot with the patient feeling that you are trying to help them to the best way they can.
Okay. Um, do you have how does your staff? I mean, I know you do everything from the blood draw to everything. Does how does your staff help you to, let's say, educate, follow up? Like, is there any specific system or a process that you have within your team that helps you to do that many injections per month?
As far as the staff, there's not a lot they do. This is more something that I tell the patients um, directly. So there are some patients that are alternating hyaluronic acid and PRP, which it seems to work one synergistically with the other. And so they're already getting booked like every 3 months for hyaluronic acid, and then 3 months later the PRP, 3 months after the hyaluronic, and that way they're
Nice.
getting, so it's almost like a schedule that they kind of agree on. It's almost like a little micro program, micromanagement that I do for
Yeah.
that.
That's a pretty good approach, actually. I wonder if a lot of doctors are using that and using that program. I mean, I know in aesthetics they have like packages that they call it, right? But that's a good approach. Yeah. Um, after 20 plus years and doing thousands of injections, I feel like you've done, yeah, definitely you've done thousands of injections already, for
More
sure.
than that,
Um,
if you count cortisone, I don't
yeah,
know. I mean, hundreds of thousands.
yeah. What's something that you used to do different early on and now you changed?
As far as injections,
Yeah.
I
Or the way
try
you
to
talk to your patients that you see what worked, something like what changed, your approach.
not a whole lot, Oscar. I would say I don't. There are doctors that inject cortisone every month. Uh, I try to not to do that. I try to separate the steroid injections of the patients that cannot afford PRP. Unfortunately, I can have them come like every 3 months for a steroid shot. Uh, but that's about it. I mean, I haven't really had anything that has changed that dramatically.
Okay. Where do you think the biggest gaps are right now in like how doctors explain PRP to patients? Like, where's the disconnect? Where's that gap that you see from your experience?
They don't provide scientific evidence. They don't provide, um, I would say,
A one-pager
not.
document or something. Maybe they talk about it, but
They don't talk more. They need to spend time explaining to the patient what are they going to get and how does it work, what to
yeah,
expect. Um, so you just cannot tell them that this is PRP. We're going to inject it to you. You're going to feel fine. They need to understand what they're getting. They need to feel comfortable with the way that they're going to uh, proceed. Because it's costly. It's not like we're not talking about a $20 procedure here. So the gap to me is because the patients are not being educated the way they should. That's to me is the number one gap.
yeah. Yeah, I mean, I agree with that, with education, because I feel like if they've been educated properly and they have a clear understanding of what PRP is and how it's going to work, I feel like they are going to invest in themselves. I like how you said this is an investment to your joint health. That's a good takeaway. Um, One thing as well, I have one more question for you. But one thing that I wanted to touch up on that I forgot and I wrote it down is that going back to how you were saying that patients they rather, uh, you know, do their face, their hair, and other things rather than fix their knees to walk better. So people rather look good, right, than feel good, right, and functionality, right. I mean, it's crazy and funny and all of the above, right, on how people decide to do that. But also, we're in South Florida, and in South Florida, we know that people there are just, they love to they rather look good, and they
Eh,
spend a lot of money doing that.
Thousands of dollars. So what good does it do to you to be looking good and sitting on a chair when you cannot jump out on the disco and or go and play pickleball
Play with your
or
kids,
right?
play with your kids, play with
I
your
just make that
grandkids, go to the
analogy to
beach.
them in a joking way, making it look it funny, but they seem to understand it, seem to get it. I said, yeah, that's true.
Yeah, yeah, it is true. It is true. We have to be reminded more than taught, right? I feel like. Um, All right. The last question before I let you go. If you could give one piece of advice to a provider who was just starting to offer PRP or thinking about offering PRP in their practice, what would it be?
I would say spend time with a patient, create a relationship where they trust you, be serious about it, provide scientific evidence, verbally or written, so that they understand that this is not a hoax, and make them feel comfortable in a way that they trust you as a doctor and as a person. That way, they don't feel like they're being ripped off. And that takes a good 5, 10 minutes sometimes in the office. But at the end, once the once the first talk goes through, you don't have to be repeating, and they keep coming because they trust you and they feel better. And that's what PRP is doing, at least in my practice.
Yeah. No, I agree. And then the biggest thing that I kind of want to emphasize here is, I believe plant a seed, right? Educate them, because I feel like even though they said no during that one consultation, that doesn't mean that it's a no for forever, right? Or for next time, right? And
Correct.
so educating them and then continue building that relationship, building that trust, with your patients, I think is will go a long way for them to make a decision for their health and decide on what's good for them at the end of it.
And I think it needs to be done by the doctor. I don't think the MA or the PA should be doing this. I think if they hear you, if it's coming from your own mouth, sitting face to face, and you show them uh, confidence, I think that they will definitely feel better and most likely feel comfortable. That's a word. You know, you have to make them feel that what you're telling them is not just this is a doctor that just wants to make money. No, they have to understand that this is something that they're doing because we're backing it up with scientific evidence and we want to make the patient feel better.
Great. Okay. Well, Dr. Ortega, thank you for your insights. Thank you for your time. I appreciate it. I'm sure you gave so much information, so much value, and I hope that if you're a provider and you're struggling on on the business side of things, how do you talk to them? And hopefully you took some really great takeaways in this interview with Dr. Ortega. If you guys want to connect with him, either send me a message or you can find him um, as in on his website, which I'll share with you guys at the in the description. Dr. Ortega, if you have any last final words for the audience before we head out.
Well, I mean, again, this is an awkward spot here where I am, but I'm glad that we were able to get it through and communicate. And again, any questions or um, I think you can give them my email as well, Oscar. I don't have a problem with that. And any questions, they can call me, or if we can um, talk by email, whatever. Yeah.
Yeah, sounds great. Yeah, I will be sharing your email and your website and all that information in the description, so in case they can find it. Okay. Well, Dr. Ortega, it's Friday afternoon. You're in Puerto Rico, and I know you have some family matters. May God bless you and your mom, and we'll
Thank you.
be in touch soon. And safe travels back to Florida.
Thank you, Oscar. I'll catch you later.
Bye, everyone. Bye, 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 bye.